Hello everybody, I'm Andy Clegg, Professor of Geriatric Medicine and Consultant Geriatrician at the University of Leeds and Bradford Royal Infirmary, and I'm delighted to talk to you today about the development and national implementation of the Electronic Frailty Index version 2. So going back around 5 years now, we led the work to develop and validate and then implement the original Electronic Frailty Index using routinely available primary care electronic health record data from around about 1 million patients in the UK in two very large data sets. I mean, this was a huge step forward, the national implementation of the original EFI, because for the first time globally, it enabled clinicians in the UK to start to identify frailty in older people using routinely available data, getting over that obstacle of a clinician needing to do an additional resource-intensive assessment to identify frailty, so that interventions, evidence-based interventions such as medication reviews, falls prevention interventions could be provided for people living with moderate and severe frailty. And this became part of the NHS policy in terms of the General Practice Contract in 2017-18 and is specified in the NHS long-term plan. So this was the original EFI, the variables that are included in the original EFI, 36 variables spanning clinical signs, symptoms, diseases, disabilities and impairments. So it goes much broader than a conventional multimorbidity or comorbidity model. And it's very simple because all that you do is you add up the number of these deficit variables that an individual has in their health record and divide it by the total possible. So for example, if somebody has 9 of these 36 variables in their record, their EFI score is 0.25, 9 divided by 36. So a very simple approach to identifying frailty, and it allows development of categories, people who are fit and people with mild, moderate and severe frailty. But the original EFI does have some key limitations. I mean, you might have spotted that there's a relative absence of mental health variables in the original Electronic Frailty Index. And one of the other difficulties is that there's no time variance. So if somebody the age of 65, so for example an anemia or 55, then that variable stays in the record typically over a long time horizon, even if the anemia has been treated and goes away. And so there's no account for that in the current EFI. And also we specified individual outcomes for the original validation, care home admission, hospital admission and mortality, but considered these in isolation. Alongside that, I've mentioned that all the variables are weighted equally. We don't weight the variables depending on how important they are in the overall measure of frailty. So for example, if somebody's got an advanced dementia, that probably carries more weight than if somebody has a historical anemia. And then there are some challenges around the frailty categories. We define the categories statistically, fit, mild, moderate, severe frailty, but there's opportunities to refine those frailty categories. And so what we're currently doing is we're addressing all of those limitations in the original EFI in our current major programme of research funded as part of the National Institute for Health Research Applied Research Collaboration Programme. And we're developing EFI version 2. So this version will include a number of mental health variables. We will look to weight the variables depending on how strongly they associate, not with just one of those outcomes, care home admission, hospital admission or mortality, but what we're doing is we're looking at the outcomes as a composite. So we've developed a composite outcome of new home care requirements, which is a new outcome, admission to hospital specifically with falls or fractures, which is a new outcome, care home admission and mortality. And we're seeing how the EFI version 2 predicts that composite outcome using prognostic modelling methods. We've done a huge amount of work using these 3 data sources, the SAIL data bank, which is drawn from the population of Wales, alongside a local data set in Bradford, and also the Research One primary care data set. All the outcomes that I've specified we're measuring at 12 months. And these are the codes that are currently in EFI version 2. So as you can see, it goes much broader than the EFI version 1, which had 36 variables. We have up to about 80 variables in this version, the EFI version 2. And they go much broader in terms of some of the functional measures. So it includes more specific problems like dressing problems, grooming problems, problems with the environment, and even higher level activity of daily living problems, alongside mental health variables, depression, anxiety, and the more severe mental health problems. The next step is actually running the validation work for that composite outcome, and over the next 6 months we're planning to run the internal and the external validation, and then move on to updating the EFI in the national electronic health record. So it's been a huge piece of work, contributions from a very wide range of participants, collaborators, both at Leeds and further afield. We're very grateful to, and hopefully we'll be able to come back to the next conference and present the final validation outcomes for the work. So thank you very much for listening. I hope this has been of interest and useful.